slideshow issue இருக்குங்க.
ஓ
I just அப்படியே ஸ்க்ரோல் பண்றேன்.
சரி,
நீங்க
ஓகே
கிளாஸ் ஸ்டார்ட் பண்ணலாம்.
ஓகே. இதில் இந்த
இல்ல மேம், எதுவும் தேவை, நீங்க ஸ்டார்ட் பண்ணலாம்.
ஓகே. Good afternoon, everyone. Able to hear me?
Good afternoon.
Can someone answer?
Good afternoon, ma'am.
Good afternoon. Able to hear properly, no?
Yes, ma'am. Yes, ma'am. Audio is fine, ma'am.
Okay. Okay. So today's topic is fibroid uterus. And next slide. So today we are going to talk about fibroid uterus, and the other names for fibroid uterus is leiomyoma, fibromyoma, and myoma. And what is a leiomyoma? What is a fibroid uterus? And it's a clinical case for you. So rather than talking more about the theoretical issues, I'll be concentrating more on clinical scenarios only. So, leiomyomas are benign smooth muscle neoplasms that typically originate from the myometrium. So the myometrium is composed of smooth muscles, and the tumor which arises from that smooth muscle is called as leiomyoma, and it is a benign tumor. Most grossly, the leiomyomas will be round, and the consistency will be rubbery. When bisected, it will reflect a whorled pattern. You would have read in your pathology, and they pose a distinct autonomy with the surrounding myometrium because of thin outer connective tissue layer. Usually it has a pseudocapsule. When we dissect it in myomectomies and during hysterectomy specimen, if we try to remove the myoma, it will be surrounded by a pseudocapsule. So because of that, the peeling off of the myomas will be so easy. Coming to the incidence, the incidence is 20 to 25% of reproductive tract tumors, and 77% of hysterectomy specimen will have fibroids. Etiology, it is genetic in 40% of people, and hormonal factors and growth factors also play a role. Hello? In genetics, it is said as because of translocations between 12th and 14th chromosome, and some say it is because of deletion of 7th chromosome, and trisomy of 12th chromosome are all implicated in the genetics of fibroids. Some specific gene mutations is also implicated in this. Coming to hormones, it is an estrogen dependent tumor. Mostly hyperestrogenic states are associated with fibroid uterus, and estrogen and progesterone increase in the receptor number, and the responsiveness is associated with fibroid uterus. And hyperestrogenic states like carcinoma endometrium, early menarche, anovulatory, and infertility are associated with it. And it is less common before puberty and after menopause, when the hormonal activity is very less. The risk factors which increases the incidence of fibroids are increasing age and endogenous hormone production. When there is deficiency of progesterone production, like as in polycystic ovarian disease, where anovulation is the common, main major problem. Chronic anovulation is the main component of polycystic ovarian disease, and in obesity. And family history, it is more 2.5 times the risk when there is a positive family history, and when in obese patients also it is very common. Coming to the classification of fibroid uterus, it is classified as in two ways. One is depending upon the location of the uterus, location in the uterus and in the cervix. So it is classified as uterine and extrauterine. In uterine also it is classified as from uterus and cervix, and extrauterine when it is arising in the broad ligaments and other areas. And depending upon the location of the fibroids, it is classified as submucous. So coming to the uterine fibroids, whether it is in the body of the uterus or in the cervix, if it is in the body of the uterus, again it is divided as interstitial, subserous and submucous, depending upon where the fibroid is in location. When it is more closer to the endometrium, it is called as submucous fibroid, and the incidence of submucous fibroid is very less, 10%. When it is more closer to the serosa of the uterus, it is called a subserous fibroid, and the incidence is 15%. And when it is inside the myometrium, that is called as interstitial, and majority of the fibroids are interstitial in location, and it constitutes to 75% of things. And in subserous, there are three varieties we can say. A simple subserous fibroid, a subserous fibroid which extends into the broad ligament, and parasitic fibroid. Sometimes fibroid arising from the uterus, it derives blood supply from other organs like some gastrointestinal tract, like a large bowel or small bowel, and then it gets detached from the uterus. Then we call that as parasitic fibroid. And submucous fibroid, that is when it is just beneath the endometrium, we call that as submucous fibroid. It can either be a sessile fibroid or it can be pedunculated. So when it is pedunculated, it can even come and come via the cervix and come to lie outside the cervix and present as fibroid polyp. And when fibroids are present in cervix, depending upon the location in the cervix, it is classified as anterior cervical fibroid, posterior cervical fibroid, central cervical fibroid, and when in the lateral sides, right or left, it is called as lateral fibroid. In cervical fibroid, the uterus will be perched up on the fibroid like a small mountain. And the other varieties of fibroids are intravenous leiomyomatosis. Sometimes fibroids may be found inside the blood vessels, especially the veins. Then it is called as intravenous. Mostly we will not be diagnosing these and before surgery. During surgery, when we strip out the veins, we might be able to see intravenous leiomyomatosis, and it is a very rare entity. And sometimes with no contact in the uterus, in peritoneal deposits, leiomyomatosis peritonealis. So it can be seen in the peritoneum of the abdominal cavity. Next. And these are all very rare. And there is one more classification as FIGO classification of fibroids, where the fibroids are classified depending upon the location as submucosal and others. Only there are two categories, because most of the subserous fibroids and submucous fibroids, majority of them will be positioned inside the interstitium only, that is within the myometrium. It might be closer to the serosa or mucosa, but most of them will be situated, the positioning of the myoma will be mostly over the interstitium. So we call that, so FIGO classifies as SM, submucosal, and others. There are only two categories. And in submucosal variety itself, there are, it is further classified as 0, 1, and 2, where 0 is pedunculated intracavitary. It means a submucosal fibroid, because of the uterine contraction, as the uterus contracts, it tries to push the fibroid inside the uterine cavity, and it becomes a pedunculated one, and it is completely inside the uterine cavity. So it is 0. SM, when we indicate as SM0, it means a submucosal pedunculated intracavitary leiomyoma. And when we say as SM1, the fibroid is submucosal only, but less than 50% of the myoma is in the interstitium, that is myometrium. It means it projects inside the uterine, it pushes the endometrium and projects inside the uterine cavity. But only less than 50% is inside the myometrium. When we say as SM2, more than 50% of the fibroid will be located inside the myometrium, but it will be closer to the endometrium. So we call that as submucosal 2, SM2. And the other category, when we represent as O, it is other, and in that it is further classified as 3, 4, 5, 6, 7, and 8. So when we say as 3, it contacts endometrium, but 100% almost 100% of the fibroid is situated inside the myometrium. And 4, completely, it doesn't have either a contact with either endometrium or myometrium. Sorry, endometrium or serosa. It is completely inside the muscular layer, and we call that is typically an intramural fibroid. And when we categorize as 5, it is subserosal. Again, less than 50% of intramural involvement. And 6, subserosal, with more than 50% of the fibroid in the interstitium, that is within the myometrium. And 7, it is subserosal pedunculated. So a subserous fibroid which has become pedunculated and which is pedunculated and lying outside the serosal area. And 8, it is others, that is like cervical fibroid, parasitic fibroid, or the rare varieties of intravenous fibroid, something like that. And further, they also subclassify it depending upon the location as 2 is 2 to 5, 3 to 5, like that. and that is not that is for PG standards. We'll skip that for undergraduates. We can skip this. And coming to the symptoms, so you have to diagnose. You'll be given a clinical case of fibroid mass abdomen. It will be given as mass abdomen because you will not be doing any pervaginal examination. So when they present to you as mass abdomen, you have to elicit the symptoms, and depending upon the symptoms, signs, and abdominal examination, you have to come to a conclusion as probably fibroid uterus, probably ovarian mass, something like that. So you should know clearly about the symptoms and signs. And majority of the fibroids are asymptomatic. 50% of fibroids are asymptomatic. Either it will be too small in size or a subserosal fibroid, except for and 30% will be having abnormal uterine bleeding. But when a subserosal fibroid will not present with any bleeding symptoms because it is farther away from the endometrium. Only when the fibroids are closer to the endometrium, it will have menstrual complaints. When it is, at least it should be inside the myometrium. When it is farther away from the endometrium, and when it is more towards the serosa, the menstrual complaints will not be there, and it will keep on growing. You can notice larger fibroids will be mostly subserosal because they are asymptomatic. They would have grown, people would not have noticed that, and they'll be thinking, most women will be thinking that too, especially after the reproductive age group, they'll be thinking that they are putting on weight or they are developing a tummy, and they ignore that symptom. So mostly they'll we have even removed 5 to 6 kilos of fibroids. Yes, they'll be presenting only with abdominal distension and no menstrual complaints. And majority of them will be subserosal fibroid, which will be growing away from the endometrium. So they'll be asymptomatic. And 30% will present with abnormal uterine bleeding. The main complaints are menorrhagia. Nowadays, we are not using these menorrhagia, metrorrhagia, polymenorrhea, or something like that. We call as heavy menstrual bleeding. And whenever you are given a case, you have to elicit the history and present as patient has come with complaints of heavy menstrual bleeding only. But you have to elaborate the history in such a way that whether their periods are regular, whether they have any prolonged history, for how many days they are bleeding, whether they have excess bleeding on that particular days, or whether they are having any intermenstrual bleeding, something like that. You have to elaborate in your history. But the complaints will be heavy menstrual bleeding only. So, when we say as menorrhagia, it is excessive bleeding on the days when they have their periods. And mostly it will be in submucous and intramural fibroids only. Most of the menstrual complaints will be in submucous and intramural fibroids. When we call as metrorrhagia, there will be intermenstrual bleeding also. And this intermenstrual bleeding will be more common in submucous fibroid polyps. And sometimes even post-coital bleeding might also be there. And that too, when it protrudes outside the cervix, post-coital bleeding might also be there. By saying as polymenorrhea, it is frequent periods. Normal periods is between 22 and 35 days. Anywhere periods occurring between 22 and 35 days is normal. When periods occurs lesser than 22 days, it is called as polymenorrhea, and mostly it will be occurring in polycystic ovaries. Polycystic ovaries have desired presenting pattern. Either they'll be having polymenorrhea or they might have even oligomenorrhea. And purulent discharge, it is because of infected fibroid polyps. And the other symptoms are pain. Pain is very rare, but pain as such on all the days is rare. But dysmenorrhea, they can present to you with dysmenorrhea. Dysmenorrhea can be either congestive or spasmodic. By saying as congestive dysmenorrhea, we mean that the blood supply to the portion, the pelvis is congested, and because of congestion, patients will be developing dysmenorrhea. And this congestive dysmenorrhea will be, they'll be giving history as they get pain just one day, even prior to the onset of periods. And once the period starts and once the congestion is relieved, their pain will go off. Whereas in spasmodic dysmenorrhea, this occurs especially in submucous fibroids, where the uterus will try to push the fibroids inside the uterine cavity. And because of that, submucous and intramural fibroids, they develop spasmodic dysmenorrhea. In spasmodic dysmenorrhea, they will not be having premenstrual pain. They will be developing dysmenorrhea only on the day when they get periods. And sometimes they might present with acute pain. It is because of torsion or some changes inside the fibroids like hemorrhage or degeneration. Some, when they develop large fibroids or because of pelvic congestion, sometimes there might be a chronic pelvic pain also. That is very rare. And some people will develop pressure symptoms. Whenever you are presenting a case of fibroid, you have to talk about all these symptoms. Even if they present to you only with menstrual complaints, you have to give negative history of all these. You have to talk about pressure symptoms also. Pressure symptoms are more common in cervical fibroids because of the positioning of the urinary bladder and ureter. There might be a cervical fibroid may present with acute retention of urine. And if the fibroids are present in the broad ligament, they might impinge on the ureter and cause hydroureter and hydronephrosis. It is very rare to develop constipation because fibroids in the posterior wall of the cervix, the gap between there is a pouch of Douglas, and the fibroid should be so large enough to cause constipation, to pressurize over the rectum and cause constipation. It is very, very rare. Very rarely, a pedunculated fibroid may cause intestinal obstruction. And infertility. Coming to infertility, 30% of people may present with infertility in reproductive age group. And this is mainly in this submucous and intramural fibroids only. Because they are more closer to the endometrium, they distort the uterine cavity and they'll be interfering with the implantation of the fertilized ovum. Sometimes a fibroid might also be present near the tube, fallopian tubes, which will be preventing the egg to come inside or the sperm to go inside the fallopian tubes and fertilize the released egg. Because of that also, it might cause infertility. And a submucous fibroid might also cause an endometrial inflammation and vascular changes, which will also disrupt implantation of the fertilized ovum. But a subserosal fibroid, mostly it will not have any effect. So whenever a patient with infertility comes, even if they have fibroids, if they are very small or if they are of subserous variety, we will not be going and doing a myomectomy for that patient. We have to exclude all other causes. We have to see the male factor, we have to see the tubal factor, and we have to exclude all other causes before we go for a myomectomy for a patient with infertility. And abdominal lump, this is more common with subserous variety. And sometimes they might also present as pseudo-Meag syndrome. Meag syndrome is ovarian fibroma with ascites and pleural effusion. When the same thing occurs with uterine fibroids, fibroid uterus, ascites, and pleural effusion, we call that as pseudo-Meag syndrome. And other symptoms are because of menorrhagia, they might present to you with anemia, and because of anemia, they might present with palpitations, dyspnea on exertion, something like that. Second, it is because of anemia, and sometimes they might present to you with vaginal discharge if it is a submucous pedunculated fibroid polyp. So the natural history of a fibroid is it's a very slow growing tumor. It grows 9% over 1 year, and it regresses after menopause. It is mainly because of the estrogenic hormonal activity. There is loss of hormonal activity. It regresses, but it will not disappear. And it has a rapid growth in premenopausal women. It indicates and in pregnancy also it has a rapid growth, and secondary and degenerative changes are also common. The secondary changes which might occur in a fibroid, we call that as complications also. It can be a hyaline degeneration, calcareous degeneration, fatty degeneration, red degeneration, necrosis. All these can happen in a fibroid. And this mostly the blood supply in a fibroids to the fibroids in the uterus is from periphery. From the capsule, it will be inside the myometrium or a myometrium, and there will be a pseudo capsule covering the fibroid uterus also. And the blood supply will be from the periphery going towards the center. Because of this pattern of blood supply, there will be the center will be getting center of the fibroid will be getting less blood supply, and whenever a degeneration occurs, may it be hyaline degeneration or cystic degeneration, the degeneration starts in the center because it is less vascular. Whereas a calcareous degeneration, it means deposits of calcium. It starts in the periphery because the vasculature is more in the periphery. The calcium deposit starts from the periphery and goes towards the center. Red degeneration, it occurs in pregnancy. It is very specific to pregnancy, especially it occurs in the second trimester, and it is because of microthrombi, which occurs in the blood vessels supplying the fibroids. And it is an aseptic condition. Pregnant mothers will be experiencing severe pain, but mostly it is managed conservatively. 99% it is managed conservatively. We don't go in for any surgical intervention at that time. They will be developing fever, pain, and everything. All these symptoms will be managed symptomatically. They'll be admitted to the hospital. They'll be monitored, and we will be giving a paracetamol and antibiotic, pain relief, something like that. And most of them will settle down with that. And other complications are torsion. A subserosal pedunculated fibroid can undergo a torsion. Torsion means rotation on its axis, whereby the blood supply to the fibroids are cut off, and because of that it undergoes necrosis, and because of that they'll be developing severe acute pain. And some very rarely a huge fibroid of the uterus itself, because of that the uterus itself will undergo torsion. That is very rare, but that can also occur. And inversion, when it is a submucous fibroid polyp, if it is too big, it tries to during periods the uterus will try to push the fibroid polyp outside, and because of that, and because of the heaviness and because of gravity, the fibroid will be pulling the fundus along with the along with it, so that an inversion of the uterus occurs. And these are all acute conditions where we have to intervene. Otherwise, patient might go in for shock. And hemorrhage might also occur inside the fibroid, and that is also an acute condition. And infection occurs in submucous fibroid polyps. It might also be associated with endometrial cancer and adenomyosis. How will you differentiate between adenomyosis and fibroid uterus? Adenomyosis will have dysmenorrhea. Even in fibroids, it will be, the people might have dysmenorrhea. But in adenomyosis, the uterus will be less than 14 weeks size, and it will be an uniform enlargement with the fibroid will have a different consistency. It is firm in consistency, whereas in adenomyosis, it will be a bit softer. So likewise, you can differentiate, and it can also be associated with endometriosis in 30% of cases. And this is a picture showing cystic degeneration, where you can notice the degeneration is more in the center. This is a picture showing the fibroid down is showing a calcareous degeneration, and the fibroid above has hemorrhage inside it. The degeneration occurs in pregnancy, as I said before. Next. And sarcomatous change. Sarcomatous, it is very rare for a fibroid to undergo malignant transformation. Only 0.1 to 0.5% of fibroids undergo malignant transformation, and that occurs only after menopause, not before menopause. But it might be coexisting. A fibroid might coexist with a carcinoma endometrium, because even carcinoma endometrium is more common in hyperestrogenic state. But the fibroid as such getting converted into malignancy, getting transformed to a malignant change is very rare. It is only 0.5%. So diagnosis is made by history, and after that abdominal examination and pelvic examination. When it is smaller fibroids, only fibroids larger than 12 weeks will be, you'll be able to feel it abdominally. Otherwise, you have to do a pelvic examination, and the fibroids will be, the uterus will be enlarged irregularly, firm in consistency. It will not be tender. In abdominal examination itself, you can move the fibroid from, there will be side to side mobility will be there. And then you have to go in for classification, and then the diagnosis is by imaging. In imaging, an ultrasound itself has a good sensitivity and specificity. MRI has 100% sensitivity, but it is too costly. And transvaginal or abdominal ultrasound, if it is a bigger fibroid, even you can do an abdominal ultrasound also. A transvaginal ultrasound has even more sensitivity and specificity. So that itself is sufficient. But when you are planning for a conservative surgical management like myomectomy, an MRI would give you a clearer picture, because you have to do a fibroid mapping, because you have to remove each and every fibroid. Otherwise, the smaller fibroids, even if it is sub-centimeter fibroids, it will start increasing, and there will be recurrence. This is an MRI picture showing the fibroid uterus. Next. This is transabdominal ultrasound. The transvaginal picture. Next. This is saline infusion sonogram. Saline infusion sonogram is very useful in detecting submucous fibroids and also submucous fibroid polyps. In this, this the picture which has a translucent area is the Foley bulb. We introduce 0.8 size Foley catheter inside the uterus, inflate the bulb and inject saline inside the uterus. And because of the fluid and the difference in you can make out, and the fibroid, if it is a fibroid polyp, you will be able to see it very clearly. And the differential diagnosis for a fibroid uterus are pregnancy. In reproductive age group, you have to rule out pregnancy, hematometra because of the enlarged uterus, hematometra, adenomyosis, bicarnate uterus, ovarian cysts and tumors, ectopic pregnancy, pelvic kidney, and chronic inversion. And coming to the management, you have to do first do investigations to diagnose a fibroid uterus, and then according to your treatment, whether you are planning for a conservative treatment, medical management, or invasive management or surgical management, you have to plan your other investigations accordingly. If the patient is anemic, you have to correct the anemia before you go in for any further management. So the indications for when do you, we have already talked as 50% of fibroids will be asymptomatic. Then will you go and intervene? Most of them will be detected on routine ultrasound. Then will you go and treat an asymptomatic fibroid? When do you go and treat an asymptomatic fibroid? When the fibroids are more than 12 weeks in size, or when it is larger than 5 centimeter, we have to treat even an asymptomatic fibroid. But otherwise, when they present to you with symptoms like infertility, recurrent pregnancy losses, sometimes when it is submucous fibroid, they might present to you with history of recurrent pregnancy loss and pressure symptoms as in cervical fibroids. A very rapidly growing fibroid, especially after menopause, you have to rule out a sarcoma. And when it is symptomatic, when they present to you with menstrual complaints, you have to intervene and treat the fibroids. It can be medically managed also. Medical management is either a temporary palliation or alternative to surgery. When they are very nearer to menopause, we generally, because after menopause, the fibroids are going to decrease in size. So when they are nearer to, in the perimenopausal age group, we try to postpone surgery till menopause. Because once they go into a state of menopause, the fibroids are going to decrease, so there is no need for surgery at all. People who are unfit for surgery, or also we can try medical management. And temporarily, when patients are having menorrhagia, and when we are when we want to buy some time for correcting the anemia and make the patient fit for surgery, till such time we can give them medical management. And even to reduce, if we are planning for a surgery, myomectomy, and if you want to do through laparoscopy to decrease the size of the fibroid also, we can use medical management. And if you want to postpone surgery for a shorter period of time, we can use medical management. So the drugs used for medical management are antifibrinolytics like tranexamic acid. This is only symptomatic. It will control only the bleeding, and it will not decrease the size of the fibroids. These are all only for time being, to buy some time to plan your surgery. And GnRH agonist like leuprolide can also be given, but it will decrease the size by 30%. It is mainly, but it cannot be used for more than 6 months because it will be giving some osteoporosis and other side effects. So we'll not be able to use it more than 6 months, and it is costly also. And mostly we use this just prior to planning a myomectomy when we want to do it reduce the size of the fibroids and do it laparoscopically. And GnRH agonist, it is under trial. Anti-androgens like danazol can also be used, but the androgenic side effects are very high. So generally, we don't prefer to use danazol. And mifepristone is also being used. Other drugs are anti-estrogens like raloxifene, fadrazole, which is an aromatase inhibitor, is also used. And progesterocerts like Mirena are also used for controlling the menorrhagia. Selective progesterone receptor modulators like uliprostol, asopresinol is also used. And the other, this magnetic resonance guided focused ultrasound, it is also non-invasive method, but the only disadvantage is we cannot use it in patients who want to preserve their fertility, because this might also end up in a hysterectomy. So it can be, the selection criteria is it can be used only when there are 4 to 10 centimeter fibroids. Fibroids more than 10 centimeter, we cannot go for the magnetic HIFU, or if it is less than 4 centimeter also, we cannot go for it. And patients should have completed their family, and perimenopausal patients are apt for this. And the distance between the subcutaneous tissue to fibroid should be less than 12 centimeter, and it should be clearly visible on MRI, because we are using MRI to destroy the fibroids. So this is a picture showing how we do a HIFU. Next. So the other option is uterine artery embolization. Here also we cannot use this for patients who want to preserve their fertility, because sometimes this might also end up in a hysterectomy. So the indications are symptomatic fibroid where surgery is not feasible. The contraindications are immunocompromised, genital tract infection or malignancy, vascular disease, people who are having contrast allergy and impaired renal function, and people wanting to preserve their fertility. This is how we do uterine artery embolization. We put in a catheter through the femoral artery, go till the uterine artery and push a silicone particles, whereby we cut off the blood supply to the fibroids. The advantages are there will be 80% decrease in menorrhagia and 33% reduction of the fibroid in 3 months. The success rate is 85 to 95%, but this is a minimally invasive procedure and it has a short stay. But the main disadvantages are the post-embolization syndrome, and there will be early ovarian failure, and we cannot preserve a fertility. Sometimes it might require a hysterectomy. Myolysis is also being done. It is done through laparoscope by using laser, cryotherapy or electrical cautery. Mostly we do it in people who have completed their family and in perimenopausal age group. And the definitive surgical management is next. Either a myomectomy or a hysterectomy. For hysterectomy, people should have completed their family, and we select patients in perimenopausal age group or in people who are having huge fibroids that too after completion of the family, even in reproductive age groups, we'll be planning for a hysterectomy. And myomectomy, when people are in reproductive age group where they want to preserve their fertility, or even after completion of family also, if they want, will not be going and doing a hysterectomy for people in reproductive age group. So in that cases, we go for myomectomy, and myomectomies can be done either through laparoscope or open myomectomy. And if it is a submucous fibroid polyps, pedunculated polyps, we can even do a vaginal myomectomy also. So either a vaginal myomectomy, open myomectomy, or a laparoscopic myomectomy. So sometimes it can also be done through hysteroscope. For hysteroscopic myomectomy, the extension of the submucous fibroid, it should be less than 50% inside the myometrium. If it is more than 50%, then we cannot be going and scooping out the fibroid through a hysteroscope. Then we have to proceed with laparoscopic or abdominal methods. Fibroids in pregnancy, it is 18%, that is 1 in 1,000. Because of pregnancy, there will be increased vascularity, and the effect because of the fibroids, even if the patient delivers also, there might be a puerperal infection, and as I said earlier, there might be a red degeneration, especially in second trimester of pregnancy in 5% of people. And it can also present as antepartum, intrapartum, and postpartum bleeding. And the indication for removal of fibroid during cesarean section, if we happen to do a cesarean section, even we can remove a fibroid, but the main complication is we should expect a torrential bleeding. But if it is a pedunculated subserosal fibroid, we can easily remove. Or if it is going to be present at the site of incision of your LSES, then you have to remove for delivery of the baby and closure of the uterus. And when there is very rapid growth with pressure symptoms, if you happen to do an LSES, then you should try to remove the fibroid also along with LSES. Okay, thank you. Any doubts? That's all? Okay, thank you.
Thank you.